recording, and we are streaming out to YouTube now.
I just heard recording is started.
Okay.
All right, well, I think we are all set to begin the first meeting of the Interim Joint Committee on Health, Welfare, and Family Services. So welcome to everyone. I will go ahead and call the meeting to order and ask the secretary to please take the roll. And I should say that when members are answering the roll call, please indicate whether you are in your LRC office or if you are working from home.
Thank you. Thank you. Senator Julie Rocky Adams. Senator Tom Buford.
Present from home.
Senator Danny Carroll. Senator Julian Carroll. Senator Gibbons. Senator Harper Angel. Senator Kerr.
Here from Lexington, in Lexington.
Senator McGarvey.
Present by phone.
Senator Meredith.
Present from home.
Senator Wise.
Present from home.
Representative Bentley.
Present from home.
Representative Bojanowski.
Present at my home office.
Representative Bowling.
Present from home.
Representative Brown. Representative Birch.
Present from home.
Representative Elliott. Representative Frazier.
Attending from home.
Representative Goforth.
Here from home.
Representative Lewis.
Present from home.
Representative Marzian.
Representative Marcian texted me saying she was present from home and she's online. I'm not sure why she can't talk
Present.
herself. Oh, there she is.
Okay, present from home.
Representative Gibbons Prunty.
Present from home.
Representative Raymond. Representative Riley.
Present from home.
Raymond's here from home.
Thank you. Representative Sheldon.
Present from home.
Representative Stevenson.
I am present from home.
Representative Tate.
Present from home.
Representative Weber.
Present from home.
Representative Wilner.
Here at home.
Chairman Alvarado.
Present from home.
Chairwoman Mosier.
I am here from my Frankfurt office.
We
So
do have
welcome. Oh, okay, perfect. Thank you. Just a few ground rules. Everyone should be muted unless you're actively speaking in the meeting. There is a way to do this on your picture on your screen. You should be able to do that. Please also mute your cell phones and dogs and children if you're joining us from home. Mark Pulliam, the IT staff, will be muting people in the background or with any background noise and turning off video for those who may not realize that their video is on. Mark will do his best to keep from televising anything embarrassing, but please do your part and make sure to wear pants if you decide to stand up from your computer. Please use the chat feature to notify staff if you want to be recognized for a question or a comment. We will do our best to call on everyone, but if we don't get to your question for time's sake, just please text me or email your question. We'll get an answer for you. This meeting will be recorded and posted in various places after the meeting. So welcome to the first meeting of the Interim Joint Committee on Health, Welfare, and Family Services. Today is June 25th, 2020. We are meeting completely remotely today in this highly unusual time. So please bear with us if there are any technical difficulties or anything unusual. If we talk over one another, we're just going to apologize ahead of time. We're going to try not to do that. I am working, as I said, from my Frankfurt office, but we do have members joining us from their home offices and outside locations as well. We continue to work diligently during this COVID-19 pandemic, trying to find ways to innovatively continue to reach our constituents and find best practices and solutions to our healthcare issues here in Kentucky. So today we're going to hear from many healthcare providers who are doing the same, and they are finding creative ways to continue to provide quality care to all Kentuckians. We're going to hear about the impact that this pandemic and the ensuing state of emergency has had, and that it continues to have on their practices. We will hear pros and cons of regulations that have been relaxed or adjusted during this time, and about plans to move forward with or without these changes. I just want to thank everyone for joining us today and for being flexible in adjusting to this virtual meeting platform. I appreciate your willingness to be here with us today to discuss very important issues. Although we're all working remotely today, our staff has gone to great lengths to make this work smoothly. So thank you to all of our LRC staff. And like I said, just bear with us if we experience any technical difficulties or inadvertently talk over one another. We're all trying to adjust. So we will go in order of the agenda so that our speakers know what to expect. I think with that, we will go ahead and get started on our agenda. The first item on our agenda is regarding COVID-19 hospital preparedness and capacity. And I would like to welcome Nancy Galvani, the president of the Kentucky Hospital Association, and Jim Musser, the vice president of health policy for the Kentucky Hospital Association. Thank you very much for being with us today, and please proceed.
Can everyone hear us?
Yes, perfect.
Okay. We're trying to make sure we have our technology correct here as well. So Chairwoman Moser, Chairman Alvarado, thank you so much for the invitation to be here today. We really appreciate the opportunity to update the committee on the status of our hospitals and fighting the pandemic. And we really appreciate the interest that you have in our hospitals. And so we have a great story to tell for you today. So as many of you know, even prior to the pandemic hitting, a number of our hospitals were facing financial challenges. And contrary to what some people might think, that has only made it more challenging from COVID-19. Some people might have thought that hospitals were going to benefit from additional reimbursement or what have you from the spread of the virus, and that we would be overrun with patients. And of course, that is very far from actuality. That has not happened. So we've been keeping in close touch with our hospitals. They've done a lot of work to quantify the losses. And so I'm here to report today that Kentucky hospitals collectively have suffered financial losses of $1.6 billion, with a B, billion dollars, just from March through the end of June. And so while federal relief funds have been flowing to the hotspots, you've probably heard a lot of that on television, the benefits coming to our Kentucky hospitals have been coming more slowly. So only 53 of the 118 Kentucky hospitals have received enough federal relief to cover their losses to date. And again, we only have quantified losses through the end of this month. So to mitigate the damage, as you probably have read, many hospitals had to resort to cost cutting and have had of their hospital employees, both in large and small hospitals, just when we were trying to fight this pandemic. So after considering the cost cutting that hospitals did, there still remains $750 million in losses in 65 hospitals just through the end of June that are still uncovered. And these losses tend to be in our larger hospitals, our urban hospitals, and our larger rural hospitals. And so Kentucky Hospital Association has been working very closely with Senator McConnell's office and our entire congressional delegation to try to get HHS to send more of that federal relief money to our Kentucky hospitals. And getting these losses covered is critical. I can't emphasize that enough. If we don't get these losses covered, it really is going to be very damaging to the long-term sustainability of our hospitals. So as you all know, the pandemic required hospitals to shut down elective procedures for a time. And at the same time that we shut down the elective procedures, of course, that was done to make sure that we had enough capacity to meet what we thought would be a surge of COVID-19 patients. And that really didn't happen because the state collectively really did an excellent job in flattening the curve of the virus. But all hospitals felt an impact, both our large and small, our rural and urban. Our hospitals that focus on physical health, but our behavioral health, our psychiatric hospitals also felt the impact of that response. And so, to be clear, neither KHA or our hospitals are criticizing the government for following the best evidence they had at the time to make their decisions. We understand that the government was trying to attempt to address a public health crisis that we didn't have a lot of information on. And when we looked at the models, it looked very dire in terms of what we thought was going to hit us. And we certainly didn't want to have the kind of tragedy that we saw in Europe. And so it was better to over-prepare, and we're happy that we didn't have the rush of the COVID-19 hospital patients. And so while there was a significant impact to our hospitals of shutting down elective procedures, we don't want to play Monday morning quarterback, and hindsight's 2020, and try to second-guess those decisions. We know that everybody was well-intended, trying to save lives and trying to make sure capacity was available if we did have a surge of those patients. We have had some questions from several members of the General Assembly about how the pandemic impacted our bed capacity, and specifically ICU bed use. And so in looking at the data, I just want to report that Kentucky hospitals have about 1,350 ICU beds available that are set up and staffed, but we were able to surge that number up to 3,228 additional ICU beds. So hospitals were asked by the state to look at how they could increase their bed capacity, how they could convert non-patient space and put more beds in there. And that's what I'm talking about when I mean surge capacity. So we did have the ability to meet the response for ICU beds had that been needed. In addition, in looking at some of the data from the state, it looked like about 40% of the COVID patients needed ICU care at some part in their stay. That seems like a high number, but that is not unexpected from what we were hearing out of Washington State, where this virus started. We were hearing that these patients were primarily in ICU. And of course, that's a very costly level of care. And so, that it's challenging when we look at reimbursement in terms of making sure reimbursement was covering the cost of those patients. Even though that sounds like a lot of use, still the raw number of patients, again, was very low in our state because we had a good job of flattening the curve. When we look at total beds, we have about 9,959 total staff beds. We were able to surge that to add another 10,000 beds. And so, you'll be hearing from some other hospitals that we're looking at, alternative spaces of where they could add beds. So again, we feel like we were well prepared to handle the surge, had that happened. So basically, we want to say that we don't want to, second guess again that we over prepared because in looking at the models, it did look like we were going to have a huge amount of cases, and the last thing we wanted was to be in a situation where we could have experienced what we saw in Europe and those reports where people were overrun and there wasn't sufficient capacity. I do want to say that we don't have a lot of data yet. So when we looked at the data, we saw a big drop in our utilization, and that occurred in early March. And so all the data is not in to really provide you an analysis, but I can talk about some anecdotal data. You know, we were in close contact with our hospitals in terms of what was happening to volume. And I can report that when the shutdown happened, inpatient volume dropped on average about 40%. And the outpatient side was much less. On average, it was down about 60%, but in some of the hospitals, it was down by as much as 90%. I mean, really, in some of our hospitals, we just had a handful of patients. Sadly, I hate to report that patients have been generally slow to return to the hospitals. Now that the hospitals are available to treat the non-emergent cases and we're providing elective procedures again. And so the volume that we're seeing now coming back to the hospital tends to be those patients that were deferred, where their care had been scheduled and then was put off. So we don't really know, once we get those people through the system, you know, really what is going to be going forward, if people are going to feel comfortable coming back to the hospital. Also, I just want to clarify for everyone that when we talk about shutting down elective procedures, we're not talking about tummy tucks or facelifts. These are medically necessary procedures that could be postponed, you know, and what we were looking at in our guidance was just putting it off 30 days, and it was basically that you wouldn't die or have serious, you know, organ failure or something like that. These were necessary procedures that we're talking about here. And resuming elective procedures is important not just for patients, because again, these are necessary services, but also these are the very procedures that are the lifeblood of hospitals. They provide the positive contributions to the hospitals in terms of finances that sustain a lot of the other services hospitals do at a loss. And so as the elective procedures have reopened, the hospitals are reporting that their inpatient beds and their volume is generally improving. And so we're looking at that maybe back to 80 to 90% of pre-COVID levels. However, on the emergency department side, we are still hearing that that is about 50% down from pre-COVID levels. And again, we're hearing from our hospitals that patients are waiting longer to seek treatment. We're finding hospitals that as people come in for surgery, it's more urgent surgery than they've had in the past. We've heard stories that people have died from heart attacks and strokes who could have been treated and might have survived, but they were too afraid to come to the hospital. We also know when talking to our psychiatric hospitals that fewer patients are seeking care, even though we know that mental health needs have increased from the pandemic. And we have partnered with the Kentucky Medical Association to create public service announcements to try to get the word out to the public that it is safe to come back to the doctor's office and the hospital. And so one thing that you as leaders can help us with is helping us get that message out there, that you know, people shouldn't be putting off care and that it is safe to come back for medical treatment. And one of the very important lessons that we've learned in the past few months is the tremendous value of telehealth, because that has allowed people to stay in their home and allow them to not have to be exposed to COVID-19. And people have generally responded well. I think they like having telehealth, and a lot of the waivers that we received were very key to allowing us to provide telehealth. Medicare had a lot of restrictions that they lifted to even allow, for example, telehealth to be provided through a normal phone line. And so we would like to certainly work with the legislature in looking at very many waivers that we would like to keep in place going forward, but in particular, specifically around telehealth. And I just thought I'd mention a couple of the things that we think are very important to keep in place going forward, and that's allowing providers to provide telehealth to patients in their homes. Sometimes there's been regulations requiring patients to be in certain locations, and also to allow telehealth to be provided both in rural and urban areas, because sometimes it was restricted just to rural areas. Would also like to allow all providers that can bill Medicare and Medicaid to be able to continue to bill and be paid for telehealth services. We'd like the reimbursement for telehealth to be equal to in-person visits. We'd like hospitals to be able to provide telehealth services. Again, we'd like to continue coverage of telehealth even through a regular phone line, because we know in certain rural areas the internet access is not always reliable. We'd like to be able to use telehealth to monitor patients in their home. And we'd like more and more services to be covered by telehealth. And for example, Medicare had a lot of restrictions they added 80 services to the types of services that could be provided through telehealth. So we want to maintain those expanded services. And then very importantly, we would like to require all payers to cover and reimburse for telehealth, including our Medicaid MCOs, and to follow the Medicaid rules for that. So while there will be a number of issues moving forward, we certainly want to keep telehealth in place, and because we know that that has been very helpful. So I'll stop at that point, and we're happy to take any questions.
Okay, I think Representative Frazier has, well, actually, let me back up just 1 second, if you don't mind, Representative Frazier. I committed my first faux pas in not calling on Senator Alvarado in his opening. So, Senator.
Thank you. I just before we started, and I appreciate that testimony. Just to let our members know, we're going to try something a little bit different this year. Obviously, we're going to have a little bit more time today, just because we're not having to deal with kind of keeping our rooms clean and having to get done. But we've been instructed. I think most of our chair people have been instructed to try to get these meetings done in about an hour and a half. Which, for those of you who are veterans of health and welfare, know that is going to be a very difficult task, because we've had some meetings that have gone marathons in the past. So we're trying to keep our meetings as tight as possible, trying to keep our testimony as tight as possible. What we've decided to do is to try to keep Medicaid oversight, which some of you are members of that committee, and maybe if you're not, to try to handle all Medicaid issues in Medicaid oversight, and try to handle more policy issues in health and welfare, so we're not overlapping testimony and hearing the same thing in two different committees. For those of you who are members of health and welfare and not members of Medicaid oversight and want to hear about that, we'd encourage you to stick around for those meetings in the future to be able to hear information on Medicaid oversight, to get some of that information, because we'll be going back to back. But we just want to let our members know that that's what we're going to be trying to focus on, is to try to divide and conquer on those issues, so that we're not all focused on Medicaid issues and health and welfare. And also the members of the press that are following, that sometimes would listen to health and welfare and then cut out for Medicaid oversight. You may want to stick around for both committees to be able to hear information regarding those issues, to try to maximize our time. So I just wanted to make sure that that information was out there. And if you would allow me, Madam Chairman, just one question for our presenters, if it's okay.
Of course.
So thank you guys for the testimony on that information for our hospitals. Obviously, the biggest concern I think we've got, we'll hear some testimony on the pandemic field hospitals a little bit later on. The things that we're hearing about, there were several hospitals that were at risk of closing as a result. How many hospitals right now do we have in the state that are at risk for closing? Have we lost staff, or are we at risk of losing staff right now? Just kind of wondering about that, if you could possibly answer that question.
Certainly. And I think I testified previously, there's about 20 hospitals in the state that we would consider are vulnerable. I won't say that they're at risk of closing, but their finances are such that they're in a vulnerable situation. They fit a lot of the criteria for hospitals that have generally closed across the country. There's been a number of different outside groups that look at hospitals that are vulnerable to closure, and that number tends to be around 18 to 23 hospitals in Kentucky. So certainly this COVID pandemic, again, if those hospital losses are not covered from the shutdown, that's just going to speed up the process, I guess is what I'm going to say. So it's very key that we get those losses covered. But then again, we don't really know what the long-term impact is going to be. We don't really know what volume is going to look like going forward. Again, the volume that we're seeing right now, we know a lot of that's the backlog of the patients that were deferred, where the elective cases were deferred, but we don't really know going forward if it's going to bounce back to pre-COVID levels. So it's really early to say.
How about staff? I know some other states are opened up at a different level of opening than we are here in Kentucky, and I've heard from people who have threatened to leave to go to neighboring states for work. Have you all encountered or seen that, or have people for the most part stuck around and are just waiting for things to reopen as far as staff?
Yeah. I have not heard that staff has been leaving the state, and we have talked to our hospitals when we were hearing that, and no one has reported that. I will say we know that there's other states that are trying to recruit people from other states actively, because they're, in fact, Arizona and Texas are the current states that are looking. They're sending that information out because they're having spikes, and they have a staffing problem. So we are always worried about that, but I have not heard of Kentucky staff leaving the state.
Okay, all right, thanks. Next, Representative Frazier has a question or a comment.
Hi, yes, thanks for being here today. It's very good information. And I just had a question of clarification, actually. The numbers of beds that you said that you were able to increase, was that within your four walls of spaces that were created, or does that include the numbers that were created as a result of the field hospitals?
So the one field hospital, I believe, is included in our numbers. So this was the surge capacity was both within the walls of the hospital, but some of the hospitals did have alternate sites that they were including in those numbers.
Okay, thank you.
Okay, thank you. Representative Wilner.
Yes, hello everyone. Thank you for the great presentation. And I'm so excited about the recommendation for continuation of telehealth waivers. We heard the same thing yesterday from the personnel cabinet in state government. And I think there will be a tremendous amount of support for this. I'm hoping, of course, that it will include extending the waivers for behavioral health services as well. And my question is this something that you're going to need legislative help to make this happen? Do there need to be statutory changes, or do you think this is something that can mainly be accomplished through administrative regs?
So we actually are starting to go back and look at the telehealth statute in the state to determine that answer, to be honest with you. A lot of it will depend upon what Medicare does. They set a lot of the standards, but of course our state laws talk about coverage for like private commercial payers. So we believe we need to relook at that to see if we do need additional legislative changes.
Thank you.
Okay, very good. Representative Goforth.
I didn't need to make a comment on here. I was just texting the group and just saying I agree with the telehealth waivers. I think it's provided healthcare access to a lot of folks, regardless of the pandemic or not. I think it has provided healthcare access to a lot of folks that generally could not get to a provider. I think we definitely have to work on whether it's regulation, statute, whatever, and make sure that we keep these waivers in place. I know in our communities where I live that in the rural areas, and I'm sure in the urban too, a lot of folks just cannot get to a provider, and this has created access to healthcare that they did not have. So I think we all need to work on this as a group. Thank you.
Okay. Thank you. I would agree with you completely. I think that this really addresses some of the access problems that we've talked about for a long time, as well as addressing some of the healthcare disparities that we also discussed. But we have a question from Representative Marzian, I believe.
Yes, can you hear me? Thank you. And thank you for your presentation. What a catastrophe for our hospitals and for our Kentucky citizens who have been sick. But my question has to do with the ACA. And I know there's movements to repeal it and put something else in place. And would that be helpful for your hospitals, or should we keep it in place? Or what are your thoughts on continuing and expanding the ACA?
Of course, we support coverage, and that is critical. We support the Medicaid expansion. That has been so important in this pandemic, of course, with people losing their jobs. And we appreciate that the cabinet has been at the forefront in, allowing people to be presumptively eligible. So our hospitals definitely support keeping the coverage in place. Kentucky's done a good job with that.
Thank you. Thank you.
Okay, thank you. Senator Alvarado, did you have another question?
Oh, I have a lot of questions, Madam Chairwoman. So I've got a couple of the things. I just want to make sure others didn't ask them ahead of time. So on telehealth, I do want to make the comment that the General Assembly did pass a really good bill a couple of years ago, and it provides pay parity when it comes to commercial payers on that issue. I had a discussion earlier today with some of our Medicaid MCOs. and we're hoping to have continued discussions. I think they've seen the benefit. We'll hear some more testimony later on today about that as well. And hopefully that we'll be able to find that. And some of the things that you've asked about locations of individuals and where that can be provided, I think we settled that in the law that as long as you're licensed in the state of Kentucky, you could be anywhere in the world to provide services for people. And I think we've seen a tremendous, that program has been put on steroids. And we're going to have a whole section today to talk about that. I thought I wanted to talk about two other things. We're going to hear a little bit about the pandemic field hospitals. Just now in retrospect, and I guess for future education, there's been the suggestion that in the event that we needed a quick surge or, we had to have the capacity to handle very sick patients, has the KHA taken a position about the thought of using certain hospitals in our state as those field hospitals? In other words, dedicating perhaps facilities that have been shut down or facilities that may not have large volumes and use them specifically for something like a COVID-19 hospital, instead of spending exorbitant amounts of money to build kind of facilities when we have some that are already open and available to do that. And I'm wondering if that's a possibility, if you could comment on that.
So let me say this. We are planning to sort of do a debriefing to figure out how we could do things better in the future. So, I certainly don't have the answer to that, but that's one of the things we want to do is say, what did we do right? What could we have done better? What might be a better approach in the future? I do know that in some areas, our hospitals actually, designated hospitals as COVID hospitals. I know the St. Elizabeth Medical System did that. That certainly makes sense. So that certainly, bears discussion as we look at, how can we plan better going forward?
Well, I know we've got a hospital right now that's not up and running. It's, out in Eastern Kentucky, Belafonte Hospital, that I'm sure would have been available with a lot of bed space and a structure and a facility that could have been used in that purpose. The second question I have is regarding some news that came out yesterday regarding a negotiated settlement that's very important, that we knew was going to be a massive budgetary item. It's been a lawsuit that's been around that I know of since 2009, that we were looking at a potential cost of over $400 million. And I know we were made aware, I think yesterday, that Senator McConnell was able to provide some, I guess, a negotiated settlement through the federal government to settle that lawsuit. And that'll fortunately, hopefully take a lot of the burden off of the state going forward, budgetary wise, and then also to provide some relief for our hospitals. Hoping you might be able to comment on that briefly.
Yes, of course, KHA wasn't a party to that litigation. It involved, I think, about 58 hospitals. But we are very pleased that I want to thank both the governor and Senator McConnell worked very hard to get the federal government to pay the federal share of that settlement. And that's very important. As many of you know, the Medicaid program does not cover anywhere near cost. And that was an old lawsuit where, years ago, it went back to 2007, where the cabinet was applying these like across the board arbitrary, what they call budget neutrality cuts. And it was very, very low. Some hospitals were only getting paid like 50% of their costs. It was very bad. And so the hospitals had gone and filed administrative appeals asking the cabinet to reconsider. And then it ended up in litigation, and two courts found in favor of the hospital. So we're really happy that it all got worked out between the parties, the state and the hospitals. And it will be, those funds are very much needed at this time.
Very good. Thank you. That's all for me.
Okay, thank you very much. I'm glad you asked that question, Ralph, or Senator Alvarado, excuse me. That was my question. So I don't see any further questions. I do want to let folks know, members know, that if you want to join the Medicaid Oversight and Advisory Committee meeting following this, you will need to log out of this particular meeting and get a log in for that meeting. And you just need to send Hillary or Chris an email for that login. So, next, and thank you so much, Nancy and Jim. We really appreciate your expertise and certainly look forward to supporting you in any way that we can to rectify this, really damaging situation for you all in hospitals across our state. And certainly we have a lot of interest in working on telehealth. So thank you. I appreciate your testimony today. Next, we are going to hear from John Inman, the Director of Advocacy and Government Affairs from the Kentucky Primary Care Association, and he will be discussing the impact on rural healthcare providers. So I'd like to welcome John, if you are with us, and invite you to share your testimony with us.
Okay, thank you, Representative Moser. I am here. Can you hear me? Make sure our technology. Okay,
Yeah.
all right, perfect.
Thank you.
So I want to thank you and Senator Alvarado, co-chairs of the committee, for having us here today, as well as the members of the committee. We appreciate the opportunity to help kind of enlighten you on the situation in rural health. Glad to see our partners from KHA are here. It's good to hear from them too. Kind of what I want to provide you with is a backdrop of our membership and the breadth of services that they provide to kind of drive the impact of. I have two CEOs here with me that are going to talk about their situations and what they've been facing in the pandemic, but to stress the importance of our membership and what they provide to the health of the Commonwealth. In our membership, we include 51 independent rural health clinics and 27 federally qualified health centers. With a combination of that, we have sites in over 90 plus counties in the state. So a great swath of those 120 counties that we have here. As far as patient lives, we treat over 1 million patients per year in the Commonwealth. Over 350,000 of those are Medicaid lives. And for our FQHCs and some of our RHCs, they treat those patients regardless of their ability to pay. They have a sliding scale that if you can't afford your treatment, then your treatment is still provided to you. So they don't turn anyone away, and have not turned anyone away during the pandemic. They've provided essential care for many Kentuckians. The breadth of services they offer aren't just primary care. They aren't just an office visit with your doctor. They provide dental services. They provide behavioral health services, substance use disorder treatment. Many cases, they're pediatric practices and OBGYN practices, and provide that valuable care for that community. And a lot of times we've heard from the Hospital Association how they have the vulnerable hospitals. Our centers operate in counties that don't have a hospital. For an example, one of our FQHCs, Primary Plus, when the Bellefonte Clinic went out, they took over the OBGYN services in Carter County, as well as in Mason County. They took over a pediatric practice. And that was the only pediatric practice between Cincinnati and Ashland. So they helped that community when they were definitely in need there. And I just say that as a backdrop because the pandemic has been very stressful to them. They have suffered great financial losses. They've suffered staffing losses. And they've done it with a resiliency. They've been able to treat their patients. They've been able to coordinate care. And they've been able to accomplish their mission in what we would say is an outstanding way. And they've been very innovative. They've set up tents. They've set up patient flow. They've set up telehealth services just to be able to provide that care. And in a lot of cases, they've seen an 80% decline in their revenues, and they've still been able to operate and provide that care. Touching on the telehealth that others have talked about, we agree with what the Hospital Association says as far as keeping those things, those waivers in permanently, as they've been a great benefit. We've seen our telehealth services explode, and in a lot of cases, it's the only way that we've been able to provide care, especially in rural services, and especially the telephone contact because of the broadband connectivity throughout the state. And I do just want to mention that we've been great partners with the Department of Public Health. They have been very valuable to our members, providing PPE and guidance and all sorts of support. So we do appreciate our partnership with the Department of Public Health. So what I want to do then is turn it over to two of our CEOs. We have Sally Jordan from Health Point, and she's in Covington, as well as some other locations. And then we have Mike Stanley from Grace Health. So I'm going to go ahead and ask Sally to present her testimony so that you get a firsthand view of what our clinics and what our health centers have been experiencing. Thank you for the opportunity.
Okay, thank you. All right, welcome, Sally, and just feel free to jump in when you can. Okay, do we have Sally? Or we can jump ahead.
We can go ahead and go ahead with Mike Stanley. They're both here to testify. Mike, can you
Okay,
hear us?
I want to thank the Interim Joint Committee on Health, Welfare, and Family Services for the invitation. And I am Michael Stanley, Grace Health CEO. Grace Health is a community health center with 8 community-based primary care sites, behavioral health. We cover 6 nursing homes, 41 school-based health sites, and a women's care site providing local obstetrics and medically assisted treatment services. We're serving southeastern Appalachian Kentucky. Grace Health's priority is to serve the most vulnerable populations, including children, older adults, pregnant women, and people with low income. But before the governor's executive order to establish guidance for seeing patients, our emergency management team and our providers, well, they followed the CDC guidelines and they created a protocol with telehealth. For many years, Co-Chairman Alvarado and I have been advocates of telehealth for improving access to care, so we were well equipped. Our providers evaluated patients on their schedule to determine the type of visit each patient would need. First, a true telehealth via the electronic medical record system, or secondly, a face-to-face, or third, a telephone call. Patients were contacted to reschedule their visit based on the provider's assessment. We did close one clinic site based on the primary care provider's assessment of an unusually high volume of high-risk patients because that was an internal medicine clinic. We have also adjusted service delivery by creating a temporary lab draw site at one of our clinics and implementing CDC guidelines there as well, particularly patient separation and social distancing. We were able to identify gaps in care, and as a result, we incorporated the inclusion of patient vital signs into the lab draw visit protocol in order to ensure providers had additional clinical data to support telehealth visits since our patients were not coming in. We communicated this to our patients through phone and patient portal, local media, and social media. For the first 5 months, ended May 31st of this year, total visits decreased 12,568, or 24% from prior year. Total in-person visits decreased by 39% from prior year. And for the same time period, the first 5 months of 2020, total patient visit revenues decreased 2,708,000, or 30 to 32% from prior year. As for staffing, Grace Health had reduction and or flex in hours from lack of patient visits, but we had no mandatory furloughs. Some voluntary furloughs requests were made for lack of childcare and health risks for employee and or their family members. So staffing reduced about 28% at the lowest point and currently reduced 12% from our peak employment. Patient visits dropped to 46% of budgeted encounters in April, which is 5,425 actual visits compared to 11,784 that we had projected. Currently, including telehealth visits, we're operating at 76% of budget volume across all service lines. And as a result of the governor's executive order, Grace Health closed 41 school-based health sites because all of the schools in our districts moved to online instruction. We were unable to provide medical or dental services at these sites. From March through May, Grace Health lost at least 4,600 anticipated visits at these school sites. Now, our emergency management team, like I said, followed the CDC guidelines for adjustments. So we implemented what's called Table Ready. It's an application that allows us to send text messages to patients when they arrive in the parking lot, so they do not have to walk into the clinic to check in for their visit. Instead, they are checked in via the app and then contacted when their provider is ready to conduct the visit. This process supports social distancing and it does reduce the risk of exposure. but there is an ongoing cost of $1,200 a month for that service. At our pediatric site, we will need to conduct alterations and renovations to support separation of sick and well children in our waiting area. Estimated cost is $70,000. In addition, we will install protective shields at other clinic sites to support safe and staff and patient interactions. We also work closely with our local health departments and hospitals. We were receiving PPE from the state until May, at which time we no longer qualified due to low volume of COVID cases. However, as you well know, we have begun to see an increase in cases overall and an increase in cases that are requiring hospitalization. Through the CARES Act, the Provider Relief Fund distributions have covered our losses through May 31st, 2020. But additional funds will be needed to cover losses from June 1st, since patient volumes are not at budgeted levels. COVID-19 cases are increasing in our service area, and patients are fearful of leaving their homes for in-person clinic visits. Expanding capacity for testing funding received from Health and Human Services was used to purchase CLIA Wave lab testing devices that will test for both COVID-19 antibody and antigen. We will need to purchase 4 generators to assure safe storage of testing supplies and vaccines, because over the past year, we've had 2 natural flooding disasters that had caused outages at multiple clinic sites, which causes temperature fluctuations in the storage unit and would result in the loss of these supplies and vaccines. And then the Paycheck Protection Program loan was utilized and adequate to bring back employees that are able to return. However, with patient visit volumes remaining low and revenues decreased, the amount is not adequate moving forward. Further, school-based health FTEs will return only if schools open in the late summer or early fall. So in closing, in over 90 Kentucky counties, community health centers with over 440 sites are meeting the challenges of COVID-19. Therefore, community health centers are one of your most valuable assets for managing any pandemic. And if I can answer any questions that you might have.
Okay, thank you very much. I appreciate your insight as well. I think what I'm going to go ahead and do is give Sally, if she's on, a few minutes, and then take questions. We have probably another 10 minutes for this segment. So is Sally with us?
I am on. Can you hear me now?
Yeah, if you can give us a quick brief, and then we have a couple of questions, that would be great. Thank you.
I will be super brief, and you feel free to interrupt me if I'm going too long, but I've just prepared some comments. So Health Point Family Care is a federally qualified health center. We operate in Boone, Kenton, Campbell, Jessamine counties. We have 6 main locations and 20 school-based locations. We serve 40,000 patients a year through 130,000 visits. We provide medical, dental, women's health, mental health, and substance use treatment. 85% of our patients are at or below the federal poverty level. Of our 40,000 patients, 25,000 are Medicaid recipients and 8,000 are uninsured. We value the guidance that we receive from the state and local health departments. We've had great working relationships with them all along, but it's been very strong and helpful through the pandemic. We quickly responded to the community needs. We began modified operations and testing for COVID-19 on March 14th, added drive-up and walk-in testing. We're very thankful for the PPE that the state provided to us until we were able to secure our own channel of supplies. While we've been able to provide services and carry on our mission, our financial stability has been greatly impacted. The cost to provide services has increased. At the same time, our volume and reimbursement have gone down. Having to stop in-person routine visits had the biggest impact on our organization. While we were able to quickly get telehealth up, Medicare and commercial payers reimburse much less. than they do for face-to-face. We were thankful that we were able to receive our Medicaid PPS rate for the telehealth visits. Still, many of our patients preferred to come in person, and we were not able to let them. Telehealth also didn't address childhood immunizations. There were many missed during the halt of routine visits, and even now, patients are reluctant to return, reluctant to bring their children in after being told to stay home for so many months. There really is a fear out there of coming to a provider's office. Our medical volume dropped 40%. Our dental dropped down to 20% of 2019 volumes. Overall of our services, even now, we're only back up to 63% of 2019. We eliminated 48 positions, which equates to 25% of our total staff. While we do intend to bring some staff back as volume grows, it had a big impact on our organization. The Provider Director Relief Fund was a lifeline for us. Our revenue is down $1.8 million or 17% over the same period in 2019. And that was even though we were running well ahead of 2019 in February. So those few months have had a huge impact. We're concerned about volumes and revenues into next year, as we probably won't have access to that large amount of funds. Our organization received $2.4 million between federal grants and the direct relief funds. It's our hope that Medicaid will continue to pay the PPS rate for telehealth, including non-video. It's also been extremely beneficial that FaceTime was a permitted mode of video. Other forms we tried to use, we found were cumbersome for patients, and they just didn't know how to use the technology and would just give up. So the telephone-only visits also helped. We do have concerns about the ability of payers being able to operate their own telehealth, both in that it will further reduce our volume, but also for continuity of care. We are thankful that we had enough cash reserves to be able to keep operating and keep serving our mission, but do have concerns going forward with this low volume, how we're going to be able to do that. So in closing, thank you for giving me the time to speak and share with you how our organization is serving the citizens of Kentucky.
Thank you, Sally. I appreciate that update very much. And again, look forward to working with all of you on finding some assistance, some solutions to some of the problems that you're outlining. I know that we have a couple of questions, or 3 questions. Senator Meredith?
Yes, thank you, Madam Chair. The question that I can have, hospitals, associations, well, I guess I'm not here. What precipitated first shutdown of our delivery system? I think the factors. One is the anticipated need for hospital districts to reduce the probability of exposure of people to COVID-19. But the third was lack of PPE, and that probably shut down as much as anything. In anticipation of having a second wave of this, we're going to make thought strategies, developing strategies to stockpile PPE. In anticipation of this, the governor's office that we have suitable stockpiles that possibly would not have to have the shutdown, because I think folks have done a great job of putting measures in limit exposure, shortage of PPE. So I would want to know, are you?
Senator Meredith, we're having a hard time hearing you. I don't know if you can type out your question maybe, or it's just really, your connection is choppy. So I'm gonna.
Yes, I'll type the question, madam. Thank you.
I'm sorry. Thank you. So this is a prime example of why we need to improve our broadband here in Kentucky. Okay, Representative Marzian, you have a question?
Thank you, Madam Chair. Am I breaking up too? Oh, not.
No,
okay,
I
good.
can hear you clear. Thank you.
Thank you so much. I want to thank the primary care centers and the qualified health centers. You work so hard, see so many patients that need it. You're our safety net. So I was also thrilled to hear that the Kentucky Hospital Association is supporting Medicaid expansion and the Affordable Care Act. And I would like to ask you the same question. What would the impact be if we stopped expansion or if we expanded to the whole state that needs it? Would your bottom line be improved?
Yes, this is Sally Jordan. Absolutely, it would be. We were prepared when there was talk of rolling back the expansion, and we had some triggers that we could pull. We planned on continuing to serve our mission, of course, but it was going to put us in some financial risk and potentially cut some services to be able to continue doing that with the loss of coverage, with those patients either not seeking care once they didn't have coverage, or with the uninsured, having to pay, and then likely most of those patients don't pay. And then certainly expanding it further, we are, of course, supportive of. We saw a huge increase when it was expanded in the number of patients seeking care. And interestingly enough, that first year of expansion, we saw patients who got coverage for the first time that had so many problems and now are being seen routinely and have those problems under control. And our fear is if it's rolled back and they lose coverage, they'll stop seeking care, they'll get sick, end up in hospitals, and actually increase the cost of healthcare in the Commonwealth anyway.
Thank you so much. You're absolutely right. And I really appreciate the answer.
Representative Marzine, if I would add to that, Representative Moser, if it's okay if I add to that. Okay. Yeah, association-wide, our Medicaid population that we treat runs anywhere from 40 to 80%. So it would be a significant impact if we were to lose Medicaid expansion for that population, as well as for our federally qualified health centers. That would create a lot of people that are uninsured, and the grant money that they get from the federal government helps that, but it doesn't cover all the expenses to treat uninsured folks. And with their current situation of their mandatory funding from the federal government being in question right after November, it would really make a substantial impact on all of our members association-wide.
Okay.
Again, thank you for what you do. I really appreciate.
Okay, thank you. Senator Alvarado.
Yeah, just really briefly, I know in preparation for this meeting, there was some discussion about some antibody testing that was going on in some of our rural health centers and primary health centers in rural areas. And some of those statistics were very interesting, and wasn't sure if Mr. Stanley or if one of you might have that information available to present. I know it was kind of preliminary. It's only a small sampling of patients, but I thought it was very interesting, and I was wondering if you had that available to present.
Senator Alvarado, can you hear me?
I can hear you now.
Okay. What we did is we did as much research as we could on those that had the best, test results. We decided to go with Solera. So we are actually purchased those directly from them and the reagents. The challenge is it was in great demand. So we're not receiving the reagents like we hoped because they're going to those areas that have, greater outbreaks. So we feel like we did choose a better system since it's in such high demand.
So have you done antibody testing for COVID-19 already? My understanding was there's been about almost 300 kits that have been done and tested on people, at least what I was informed of, and at least half of those had positive antibodies already. And I wasn't sure if you had that information here, but that's what was disclosed to me. So that's why I'm curious if in a small sampling, if we're seeing that, what that indication could be on a larger scale for our state.
Yeah, we don't unfortunately have that data yet because we've not received those reagent kits for the antibody.
Okay, thank you.
This is Sally Jordan. I'd like to add that we have not tested patients yet. We're still waiting for guidelines for how to treat patients and what to do, what protocols to follow once there is more research. But what we did do was we did the Abbott, we did the Abbott lab test, not the time of service test, but we did the Abbott blood test, and we tested 100 of our employees who were working with COVID patients, COVID positive patients, and working in our offices, and all came back negative. That test was done starting end of April all the way through mid-May. So it's just a small sampling, but that was across all counties where we operate, again, Boone, Kenton, Campbell, and Jessamine. So we thought that was interesting. We had expected that there would be at least some positives, but there weren't at the time.
I know there are other members of your organization that have given me different results for their region, which I think they're probably a bit more in the eastern part of the state, that they were surprised to get. They claimed, at least from what they had reported to me, about half. But again, if it hasn't been a system-wide effort, you'll probably get pockets of results based on that. I was just curious if you all had any data, but I appreciate that.
And Senator Alvarado, we do have a continuous feed from HRSA on all our association-wide testing, and we can send that to you after the meeting, as well as we've taken some surveys of our rural health clinics that aren't part of the HRSA data, only the FQHCs are, and we can send that to you and Representative Mosier and the rest of the committee if you'd like.
Yeah, that'd be great. I think it's important for the for the press to know that also, just in terms of if we're there's a lot of focus on vaccinations, hopefully being ready by the end of the year or start of the next year. But if people have an antibody response already and they have a positive IgG, which is a type for previous and old exposure, those people are effectively vaccinated, and it'd be an indication at least of parts of the state as to how many people already effectively have a vaccine. And that would make a big difference to give us an idea of where we're at as a state. So I was just curious. I know there's been a lot of questions about the quality of the testing and that sort of thing, but if it's a legitimate test, we've got some results. I think it's just important to get that information out there. But yeah, that would be great if you have some of that information. We'd appreciate that.
Yeah, absolutely. We'll send that to you. Thank you.
Okay, thank you. Senator Meredith sent me his question, and he wants to know if there's a strategy for stockpiling PPE for all healthcare providers to prevent or at least mitigate a shutdown of healthcare if a second wave of COVID-19 hits us.
And I'll answer that question for the association. We've actually started a network of purchasing and reaching out to different vendors and trying to get those PPE supplies for them. So for our association, we're trying to stockpile and prepare for the next wave were that to come. We hope it doesn't, but were it to come, we're trying to get that done. As I mentioned, the Department of Public Health was a great partner for us, and they were really very beneficial for us in the beginning of the pandemic and providing those supplies. It was a bit hectic getting them, but they were very valuable. But we decided as the association to try to make our own backup plan and not have to rely solely on the state reserves.
Okay, good. Thank you. Representative Prunty is our last question. You're on the phone, so if you can hear us, go ahead and ask your questions. Okay, I do not hear Representative Prunty. If there's a way to unmute her on our end.
Can you hear me now?
Yep, we can hear you.
Okay. My question is for Sally Jordan. You made a comment in your comments that you have a concern about payers providing telehealth. Can you just expand on that? What your concerns are?
Yeah, so our concern would be that, one, they don't have all of the patient's information that we would have. So we do have, our providers have a concern with the quality of care that they may get, because whoever that payer providing that information may not have all the details on that patient. They don't have their chart in front of them. They don't have all the provider notes. And so that's a concern. Also a concern about us getting that information from that payer that the patient had a visit and what happened. Otherwise, there would be a gap. The next time we saw that patient, we might not be aware of something that's going on. And then, of course, we are worried about that taking visits away from us. We're already seeing patients self-select to stay home and not seek care because they're afraid of being exposed. And we're afraid that will just further reduce our volume and then our revenues and our ability to continue operating at the level we are.
So are the payers, the Medicaid, the MCOs?
I don't know how many of them are doing that. John, do you know who and of the MCOs is doing that currently or talking about doing it?
I'm not sure how many of the MCOs are doing it right now. I think that at least a couple are. We've seen it more in the commercial realm, where they operate their own telehealth network, and it is valuable in some way. But like Sally said, it does hinder that continuum of care and having their actual primary care provider get all that essential information.
Okay. Madam Chair, do you have something anecdotal?
Yes, that's fine. One more.
Well, I appreciate Representative Marzan's questions as to the Medicaid expansion, and I do want people to get access to care. Do you all have any anecdotal comments on the failed 1115 Medicaid waiver? Because as a former PT who did home health physical therapy, I saw where the minimal requirements of 20 hours a week, volunteering, going to school, or working were minimal to try to put people on a path towards self-sufficiency. Do you have any comment on whether that would be beneficial in this realm? And if not, that's okay. I know you may not have data. I just wonder what your experience speaks to.
I'll defer that to Sally or Mike if they want to talk, if they have any anecdotal from any of their patients at their clinics.
I apologize, but the phone cut out a little. Could you repeat that question? Can you hear me?
Yeah, we can hear you.
Did she not hear the question?
Yeah, she didn't hear the question, but
I did not.
I'll save it for another day. I'll save it for another day. It'll be fine.
okay. All right. We can just touch base about that later, or you can have a discussion offline. Okay, I really appreciate this conversation. There's a lot more to talk about, I know, and I don't mean to cut anyone short, but I think that there are a lot of things that we can do. It sounds like to kind of bolster the care that we're providing in rural healthcare settings. So I look forward to working with all of you. Thank you very much for your presentations today. We are going to move on to pandemic field hospitals now. We have with us Bart Harden, the Director of Government Relations for the University of Kentucky, and Barry Swanson, the Chief Procurement Officer for UK, and also Shannon Rickett, the Assistant Vice President of Government Relations for University of Louisville. Thank you all for being here. I'm going to go ahead and mute myself, and the floor is yours.
Good afternoon, Chairman Moser and Chairman Alvarado. Can you hear me?
Yes, we can hear you just fine.
Okay, thank you. For the record, again, I'm Bart Harden, the Director of Government Relations for the University of Kentucky, and I have with me Mr. Barry Swanson, our Chief Procurement Officer. We've been asked to talk about the COVID-19 alternative care site that UK Healthcare constructed in Nutter Fieldhouse back earlier in the spring. I think what I first want to do is make a few remarks. We'll walk you through the timeline, and then we'll be happy to answer any questions you have associated with this alternative care site that we developed. I guess to begin with, we're thankful that we're here discussing why we had excess capacity as opposed to trying to justify why we were not prepared and we were overrun by COVID-19 cases. I think that might be one of the most important things that we take out of this discussion is that we were proactive based on a lot of information. UK Healthcare was founded in '57 under the leadership of former Governor A.B. Chandler after a series of studies demonstrated that there was a crushing unmet healthcare need in the Appalachian region of Kentucky. From that, UK Healthcare has grown into a level 1 trauma center. It's the largest academic medical center in the state. It's comprised of 2 hospitals with 887 acute care beds. 160 of those are ICU beds. We are a level 4 NICU, and we have an NCI designated cancer center. And in addition, we have 70 clinics that exceed 2 million visits per year. UK Healthcare continues to honor its core mission of the service to central, southern, and eastern regions of the state. All these things played into the decision for us to move forward with the alternative care side. Our service area includes unique demographics that puts that region at risk for shortages of hospital beds, ICU beds, ventilators, and not to mention an overly sick population in general. As we begin on the timeline of this project, as the COVID-19 virus began hitting the United States in the late winter months, UK Healthcare began looking at the data and projections to get the best guesstimate of how we would be impacted. We used every available tool, which included the Center for Disease Control, Health and Human Services, the State Cabinet for Health and Family Services, UK Infectious Disease Professionals, UK Public Health Professionals. We consulted with Baptist Healthcare and St. Joe Hospital, as well as the Fayette County Health Department. On or about March 25th, UK Healthcare ran what we referred to as a CHIME model, which is specifically developed to project COVID-related spikes. And they projected we would have a hospital census of 1,575 patients. 619 would require ICU beds. It was after this modeling, in consultation with all of the decision makers, that President Capilouto, along with his team of Executive Vice President Mark Newman of UK Healthcare and the Executive Vice President of Finance and Acting Chief of Staff Eric Mundy, made the decision to move forward with the alternative site at Nutter Fieldhouse. At that point, we did inform the Bashir administration of our plans to construct 400 additional beds. These beds were going to be a bit unique in that they would be transition beds from sick patients. Once they began their recovery, they would be transitioned to this facility so they could transition back into the community. I think with that, I'm going to turn it over to Barry Swanson and let him talk you just through the procurement process for a bit once we made the decision to move forward. Barry?
Okay, thank you, Bart. Thank you for the opportunity to appear today and to present my comments on the process that was utilized to set up our field hospital here in Lexington. As Bart said, after the decision was made to pursue this, the request came to my office, the procurement division, my role as Chief Procurement Officer, to do the contracting for the necessary items to set up the field hospital. We wanted to get this set up in very short order. By mid-April, I was handed this project on the 26th of March. We immediately, and we wanted to have 400 beds, turnkey solution, operational by mid-April. And so me and my staff worked with, we did our due diligence, did the research. We ultimately were working with 6 suppliers that were requested information from them. We narrowed it down to 2 suppliers and ultimately selected EDS as the only truly turnkey solution that would meet our needs. The other finalists, we would take some piecing of various parts and pieces together, which we thought was risky, and we never really did get a firm estimate from them. So really it came down to EDS as the clear winner of the project. So once we started to focus in on them, we did our due diligence. We ran the company's background through our payment works process, which goes out and checks to see that there's no debarment issues. We did the further step of checking the federal websites directly. We got made sure we got our insurance certificates in place. We checked to make sure all the business filings were in place. We signed a contract on April 2nd, and they started construction on April 3rd, and it was operational on April 10th. We ultimately, and so it was operational on the 10th. The contract called for, it was a 30-day contract with rights to terminate with 72 hours notice. We issued termination on May the 7th that we weren't going to renew for an additional period. And so that's the high-level 50,000-foot flyover of the process we utilized.
Thanks, Barry. I think at the end of the day, we were fortunate that UK Healthcare did not utilize any of the additional 400 beds we constructed. Once we got a little deeper into the timeline of the pandemic, as Barry said, the decision was made not to renew for an additional period of time beyond the original contract. The total spend to date on that project is about $7.3 million. Approximately 6.7 of that million, $6.7 million of that 7.3 went to disaster and emergency services. We have made a request of FEMA for reimbursement. To date, we have not been told anything. We asked again as early as the first of this week where that status was. We have not been communicated anything whether we will get reimbursed or not, but we are still waiting on that. I think the university stands firm in our belief that given the information we had at the time, we made the best and the correct decision in the interest of the citizens of the Commonwealth and specifically the citizens of our primary service area. With that, I think that is in a nutshell this project, and I'll be happy to answer any questions members may have.
Okay, thank you. I think I'm going to let Shannon go ahead with your presentation, and then we'll take questions. Thank you.
My presentation is pretty short. I'm Shannon Rickett, Assistant Vice President for Government Relations at the University of Louisville. We are here today to talk about the field hospital in Louisville that was set up at the fairgrounds. U of L Health did not play an active role in setting up the field hospital in Louisville. We were aware of its location and capacity and capabilities, but did not participate in the development or operation of the site. At the time, it was unclear how pervasive the coronavirus might be in Metro Louisville. We understood that if our health system or other health systems in the Commonwealth became overwhelmed with patients, that the resources of the field hospital would be available. Thankfully, due to social distancing and efforts of public health, U of L Health did not have to transfer patients to the Louisville Field Hospital. Thank you.
Okay. All right. Thank you. I appreciate this background information, and I know that we have a question from Senator Alvarado.
Yeah, thank you. So really briefly, I guess, so what we're understanding, we've had a lot of questions about this, a lot of constituents who obviously hear about $7 million being spent on a hospital that's never used. And you have people standing in line waiting for unemployment insurance benefits, and they're frustrated. And they're saying, how come we're spending money on that and we can't help our folks at home on other issues? And I know there's a separation of monies, but that's the perception from a lot of our folks back home. In Louisville, do we know who made the decision? I mean, if we had a field hospital at UK, and it sounds like on April the 10th, the contract was signed. In Louisville, do you have any idea of the timeline of when the decision was made to build the field hospital in Louisville as well?
I do not.
Yeah, so that's part of the information that we're hoping to get is to find out who made that decision to do the one. Because obviously UK called the shot in Lexington. Dr. Capilouto did. It's what it sounds like. But I'm trying to find out if in Louisville, who made that decision, when it was made, how much money was being spent, where did that money come from, and that's what we're kind of curious about as well. Do you have any ideas to who that would be? If we can invite them to come by and answer those questions for us as well.
I believe it was the state, and what I read in the newspaper was the National Guard, but I do not have any more detailed information.
Okay, so that's one thing we'll have to see if we can get some answers at some point from that. And then from UK, I guess the other question becomes, obviously there's, anytime you get the public universities involved with something, a decision like this, sounds like you're applying for FEMA. If FEMA doesn't provide the funding for that, is that just going to be a loss to the University of Kentucky on its bottom line? Or is that going to, again, is that added to the costs and students will have to pay for in the future, the taxpayers have to pay for in the future? That's what a lot of people are asking us as to how that's going to be handled.
Thank you for the question, Senator Alvarado. Good question. I think let's take a worst case scenario here. If in fact we do not get any reimbursements from FEMA, it would be a loss to UK healthcare. It would not impact students. UK health, there are no general fund dollars in the university side of healthcare. Healthcare is a self-sustaining entity, so it would be a loss to UK healthcare, and it would be an operational loss. It would not impact students at any level. It wouldn't impact the taxpayers at any level, in as much as there is no general fund dollars put into the hospital facility.
All right, very good. That was I think that's a perception that people had out there, was those funds were going to be paid for by taxpayers. And I guess the Louisville facility, if the National Guard had made that decision, and again, the concern there becomes if it's a state decision, who on the state level, and if there's state dollars being used for those. And what I would encourage everybody to do, again, there's a lot of other hospitals outside of the Fayette County border. You have hospitals in Georgetown, you have hospitals in Paris, Winchester, that can house patients as well. And if there's looking for a surge, is to start using dedicated facilities for that purpose, instead of having to generate that. If it's a loss to the healthcare system, then those are, I think, a lot of the concern that people wanted to have those questions answered. So I appreciate your guys' testimony and willingness to come and at least provide us a few questions or a few answers.
Okay, I have a message here from Adam Mather, our Inspector General, who says that he can answer. So if you are on, I will open the floor to you for a sec.
Yeah, sure. So I can help answer some of the questions about the field hospital in Louisville. That was done with the Kentucky Emergency Management Department directly through FEMA and approved through FEMA. I think the cost to FEMA is roughly $2 million, and the original plan was about $125 million. Significant difference there. And in reference, Senator Alvarado, to the Belafonte Hospital, there were some deferred construction deferred maintenance issues that prevented us from utilizing that as a viable option going forward. And I'm happy to answer any questions directly about the field hospital.
So when was the decision made at U of L to go ahead and go forward with that and contract that work?
I don't think U of L had any. I don't think U of L made any decisions on that at all.
Right. No, but you're saying the decision was made to do something over in Louisville, correct? To do the hospital there?
At the fairgrounds itself. Correct.
Correct. So when was that decision made? That's the question that people have had. Was that made on April the 10th?
I came in later, so I can't actually answer that. I just once that decision was made, I was asked to head up the project.
Yeah. So I guess that's the question that people want to know is who called the shot? When was that decided? I mean, and a lot of that just depends. I mean, and again, a lot of taxpayers are concerned about state dollars, but FEMA is federally funded from federal tax dollars that people pay as well. And so that's what a lot of the concerns, if you have an idea of when that was decided, it sounds like UK signed a contract on April 10. I'm looking at the graphs here of where we were at that time. So if it was done after the fact, before the fact, I mean, the longer this went on, it became clear that a lot of the projections weren't going to be accurate on this. So that's the curiosity that I have. And I think a lot of people here,
Yeah,
at least in my
I know sorry to interrupt you. I apologize. I know we opened it on the 15th of April, so we had about I would say a 2-week lead time to get it open.
So April 29th, somewhere in there. Okay. We'll ask for some more.
I'll get back to you with the exact. I'll get back with you on the exact. I'm sorry, on the exact dates.
Right. Appreciate that. Thank you.
You got it.
Okay, thank you for jumping in and helping out with that question. We have a question from Representative Bentley.
Can you hear me now?
Yes, we can.
Okay, thank you very much, Madam Chair Lady. Dr. Alvarado, I kind of concur in everything you're saying about this, and I'm really a little bit confused. We have real hospitals going in debt, yet we are putting money elsewhere that's not producing. I'd like to know what the total costs were on at U of L and U of K. If Mr. Mather said it was $2 million presented, I mean 125 million presented, and only spent $2 million, and the news media says $7 million. I'd like to know what the true truth is too, and what was really the true cost. Or, you know, if we don't take care of the rural hospitals, there won't be any feeders to the major hospitals, and they'll all fall on their face. A year ago, it was like 12 rural hospitals that were having problems, and today, the association from the hospitals had it up in the 20s. So it's gotten worse. So that's my question. What was the true cost of those 2 field hospitals?
This is Bart Harden with the University of Kentucky. To date, our cost associated with the field hospital at UK is $7.3 million. $6.7 million of that went to the contractor for the rental equipment and the setup of the facility. The other $600,000 were a lot of associated costs, whether it be training, equipping.
Yeah, there was one additional large expenditure beyond the field house setup, and that was to purchase the oxygen manifolds that were required for the facility, some $321,000. We own those, we have those, we are going to use those in the healthcare enterprise. So that investment was made for the field hospital, but that is now an asset of the University of Kentucky. The rest of it was supplies and training and so forth, the additional $300,000.
Thank you.
I can answer for the field hospital at the fairgrounds. So, yeah, the Army Corps of Engineers put a proposal together for $125 million. We spent, I think, roughly $2 something. I don't have the final figures, so in the low $2 million. All of the stuff that we did receive, we still have and will stay with the state. And in reference to the rural hospitals, this was not to detract or take away from any of the existing hospitals. This was purely in an emergency sense to help the burden to have patient throughput when there was additional beds needed in more acute care settings.
One follow-up question, Madam Chair Lady. This is Representative Bentley.
Okay. Yeah, that's fine.
That's $7.3 million that UK paid for that. Did that all go to EDS? That's my last question.
No, sir, Representative Bentley, it did not. 6.7 went to EDS.
Okay. Thank you, Madam Chair Lady.
You are welcome. Senator Julie Rocky Adams has a question. Senator Adams, do you have a question? We're going to come back to Senator Adams if she wants to ask a question in a few minutes. Senator Carroll?
Can you hear me okay?
Yeah.
Okay. My question is, and I'm a little confused on the hospital at the fairgrounds. Was that all paid for with federal dollars? And if there were state dollars, is there any truth to information that's going around that it was a donor to the governor who was given the contract? And if there were state dollars used,
Am I telling me?
the contract ended, what was the process?
To my knowledge, this is Adam Atherton, Senator Carroll. To my knowledge, there were no state dollars used for that, and there were very few contracts. We purchased some beds from larger companies, and those beds we still have. A lot of the materials that we used were from our existing emergency management field hospitals, and then clearly the fairgrounds is a state property, and so there was no rent charged or anything of that nature. But there's no, to my understanding, there were no state funds used in the project.
Okay, thank you.
All right, thank you. If everyone could mute their phones if they're not speaking, that would be helpful. We'll eliminate some background noise. Senator Adams, do you want to ask your question, or did you want me to? You typed it out for me. Okay, the question had to do with the $2 million for the University of Louisville Hospital, and she just wanted to know if you said that FEMA has already reimbursed those expenses.
I just want to clarify, it's not a university did not play a part in the field hospital, so I just want to clarify that. And then secondly, I'm not sure where they're at with. To my understanding, it has been approved. I don't know if the money has been received yet or how that functioned thus far.
Okay. I think those are all the questions that we had regarding this. I think, one question that I would have is, and we heard a little bit about the hospital capacity and preparedness from the KHA earlier. And so, given all that we know now about this virus, and of course, we didn't know anything about it a few months ago. So, the preparedness, is understandable to some extent. But now, knowing what we know, do you anticipate that UK and U of L have the capacity to deal with any secondary spike if we should see one? And is there a possibility of utilizing some of our rural partners in our hospitals if needed?
This is Bart Harden with UK. I actually asked that question yesterday of some of the healthcare folks, and I think just wanted to make sure we would not be in a position if we got a large spike that we would be considering doing a second field hospital. The answer to that is no, we have moved beyond that. I think now that we have had some time to I guess, look at the pandemic as it has unfolded, in addition to look at our own facilities, we believe we can do some things internally that should help us handle a spike should we get that. For example, one of the things that was told to me yesterday, now that we see and have some experience with this, is that we could actually double bed some of the Pavilion A of the hospital to increase our bed space. So there's some things we've looked at and we've learned in this process that we should be better able to handle a spike should we see one in the fall.
Okay. All right, very good. Well, thank you. This has been informative. I appreciate your input and your testimony, and we all know where to find you if we have any other questions. So, thanks. We are going to move on because we need to be wrapped up by 3 o'clock, and we have a pretty extensive presentation on telehealth. So, I am going to welcome Paul Brophy, the Executive Director for Employer and Individual United Healthcare. I think I kind of botched that. United Healthcare Kentucky Executive Director. Kevin Crawford, External Affairs for United Healthcare Kentucky. We also have with us Dr. Brent Wright, the President of the Kentucky Medical Association, and Dr. Sheila Schuster, a licensed psychologist and the Executive Director for Kentucky Mental Health Coalition. And then Donna Vino is the Program Manager for Kentucky Telehealth Program. We also have Robert Putt, the Executive Director for the Office of Health Data and Analytics in the Cabinet for Health and Family Services. So I'm not exactly sure who wants to go first. I know, Donna, that you have a PowerPoint, as does Dr. Schuster. I would just ask that we try to pack all this in the next 20 minutes. So, Donna, do you want to go ahead with the Cabinet's proposal for telehealth?
Yes, we'll go on and start, and Robert's going to start first.
Thank you.
Give us just a second. Okay, can everyone see it, our presentation and hear us? Okay, thank you.
Okay. I'm Robert Putt, Executive Director of the Office of Health Data and Analytics in the Cabinet for Health and Family Services. And what we'd like to do real quickly is quickly give you a very short background relative to telehealth in the Commonwealth and state government, talk organizationally of where we exist and why the benefits of it, which I hope answers some of the previous concerns mentioned by some of the other speakers. And then we will talk about how we have approached telehealth since the program was moved within the cabinet, where we have seen benefits of telehealth to behavioral health programs within the state and to Medicaid services within the state, and probably end up making a few recommendations at the end of the presentation, if that's all right. So quickly, in 2000, we know that a Kentucky Telehealth Board was established by the General Assembly, and its primary purpose was just certification of for the practice of telehealth. In 2018, Senate Bill 112 was passed with an effective date of July 1, 2019. So that moved telehealth within the state entity from being a board to being a program within the Cabinet for Health and Family Services. On July 1, 2019 was when that transition actually happened. Along with that, via emergency regulation, Medicaid parity for reimbursement was established for telehealth services on that same day. Secretary Meyer at the time placed the program in the Office of Health Data and Analytics. We'll talk about that and why in a minute. December 6, 2019, the ordinary version of Medicaid parity became effective, which was very broad and allowed for many of the things that we've heard from previous speakers to happen that would not have been otherwise. We added staff relative to a clinical specialist that had been planned for quite a while to assist with telehealth programs moving forward and the implementation of it. Based on the past legislative session, July 15th, approximately, the Division of Telehealth Services will be formally established via Senate Bill 123. And we anticipate a division director being hired and an advisory council being established in the next quarter. So telehealth was placed within this department for several reasons. One, with telehealth, especially pre-COVID and during COVID, Privacy is an important matter. HIPAA regs are important, obviously. And how we approach telehealth, what types of procedures, practices, tools, et cetera, that make sense to the program are all important. So that's why the Chief Privacy Officer exists in the same organization, along with Donna, in the telehealth program. In addition, health information, which is in the bottom of that, Andrew Bledsoe is my deputy. That is KHI, or Kentucky Health Information Exchange. Someone asked the question about when you have a provider seeing a patient who they do not know and do not have their records from their EMR or EHR system, how do you get that background? KHI. The KHI e-provider portal, which has been revamped, the platform has come up 10 years, a decade in technology. That's where you can see the clinical information as a provider with a patient in front of you and give them the best service as they just state their symptoms, so to speak. Also, how do we measure the effectiveness of telehealth over time? And how effective is it? And we've heard wonderful stories about the good outcomes from using telehealth, but how do we measure it from long-range improvement in health, hopefully reduction in transportation costs, overall efficiency and access to healthcare? And that's why analytics is sitting there surrounding this program, so that we can come out with hopefully the full package in promoting telehealth consistency across the Commonwealth. So the mission, as in statute, is twofold. One, to implement telehealth services, develop standards, guidance, resources, and education to promote access to healthcare services via telehealth in the Commonwealth. And second, to provide oversight and guidance and direction to the Medicaid providers, since that is the primary medical program overseen within the cabinet, delivering care and using telehealth. So Donna and I sat down July 1 last year and said, how do we do this? And we said, well, let's first look internally at the cabinet, at programs where we could use telehealth to potentially reduce expense or create more access. And so we met with each commissioner of each of the departments about various options and opportunities for telehealth. Second, we said there's a lot to be done out there. We actually had 12 objectives for the program going forward. And in those 12 objectives, we said, we're going to need some help from the outside. So this has been literally a very good partnership of various departments, cabinets, within state government, as you can see listed on the Interim Steering Committee, along with external participants from associations and other important members of the healthcare community in Kentucky. The steering committee oversees at a high level the objectives of the program going forward and receives updates, meets about every other month, as in ensuring that we stay on track, so to speak, with obtaining our 12 objectives. So looking at the steering committee at a high level, we said, okay, we've got multiple objectives, multiple subjects. The only way we're going to get this done is with work groups. And literally the work groups have been staffed from volunteers throughout the state who have come from subject matter expertise in various areas. And you can see this list of the 10 work groups that are to be established or have been established. 3 of those work groups met this week, are meeting this week, Monday, Tuesday, and Friday, in the middle that you see. And you see that early on we have started with some other work groups. So these work groups run in membership somewhere between 10 to 20 folks who are willing to get their hands dirty and assist with developing procedures, practices, recommendations around telehealth. And all this was pre-COVID-19. So I'm going to turn it over to Donna, let her talk a little bit about the work groups that have already occurred, and then we will lead into a discussion about COVID and our behavioral health services and COVID and our Medicaid services.
Thank you so much. One of the work groups that was established back in February is the School-Based Physical and Behavioral Health Work Group. And is led by Eva Stone, and she works for the Jefferson County Public Schools. It has 5 subcommittees: communications, data implementation, service coverage and reimbursement, and technology. We have tasks and deliverables that are established for each of the work groups. And one of the most important thing is preparing a survey and conducting a needs assessment to identify the school-based telehealth clinics that are already in place. And we want to make sure that as we're working with this work group, that we integrate telehealth into the school-based programs and the free care for students program as well. This work group is also charged with developing policy, guidance, and best practices for using telehealth in the schools, as well as technology standards and communications and marketing tools. Our second work group is the Privacy and Compliance Work Group, and it's led by the CHFS Chief Privacy Officer. And that will be looking at guiding principles and policies for telehealth for privacy and guidance and compliance, and also looking at HIPAA-compliant telehealth practices and procedures and software. We want to make sure that we're covered in terms of business associate agreements as individuals go out and buy their HIPAA-compliant applications. Looking at criminal penalties, we want to make sure that people understand that there is privacy and security penalties if they don't adhere to those, and that also there is an anti-kickback statute and a Stark law that everyone needs to understand. Also providing information like etiquette checklists and informational tools and educational tools. That work group will also provide that. Our third one is research and grant opportunities, and or funding opportunities, and we took a group of people and looked at all the grants that were available and identified all of those. And as we move forward with meeting with the individual programmatic areas in state government, we're looking to see what we can actually go after in terms of federal funding. Most recently, we worked with the Department of Public Health, and we prepared a application that will be sent to the FCC, and they had $200 million that they could award, and I think they've awarded $130 million to date. Our particular application is it's a little bit under $1 million, and it is for putting the connectivity in each of the health departments with the FirstNet Disaster Emergency Preparedness Network, as well as putting remote patient monitoring equipment in at the health departments. And we are looking to and are discussing with public health right now as to the health departments possibly being community hubs where individuals could go in if they need specialty care. They could go into the health department in their community, which would save them a trip of transporting them to medical centers, and they could link to their specialist through telehealth technologies. We're also looking at libraries and working with Veterans Affairs, try to determine what would be an opportunity for the libraries and the veterans to be able to connect to their services. Okay, then we have the Policy Development Work Group. And prior to COVID, the program, and it was about, I guess, July 2019, decided that we needed to look at all statutes and regulations that deal with telehealth. And as we were beginning to put all those together, we have a document that's about 21 pages long. And even though we have a parity law in the state that says coverage and reimbursement shall be at the same rate as face-to-face service, we're finding that a lot of the professional licensing boards have regulations that don't include telehealth, or they have specific requirements that where you cannot use telehealth for the first visit. You have to have an individual in-person visit before telehealth can be used. So we've got a document of about, like I said, 21 pages there, and we've already identified all those statutes, and we hope that document will be very helpful as we move forward. This work group also put together a lot of information in terms of the correct coding across all payers because it's all different. So if you're trying to do analytics from the back end, you've got garbage from the front end because you don't have any consistent standardized coding. So we're looking into that as well. This week, we had 3 work groups convene. The local health department work group, which I am leading that one, the workforce development, education, and outreach work group, which Diana Weiss Posh is a nurse that we just hired. She's a telehealth clinical specialist and a master's in informatics and an educator was an educator at BCTS. So she brings, or BTC, I'm sorry, BCTC. And she brings a lot of knowledge. Been in telehealth for about 25 years, so she brings a lot of knowledge to our program. The other work group is the Behavioral Health and SUD Treatment Work Group, which met yesterday, and a lot of good information came out of that work group as well. We've got 3 more work groups in the future. Would be the telco and security, disaster preparedness, and what's the third one? Metrics. So we want to be able to determine what the value of telehealth is as we move forward. Okay, so I'm going to turn it back over to Robert, and he's going to do the behavioral health side.
So in behavioral health, we met with Commissioner Morris, and she provided us a lot of valuable information. And in that, she said, I really am very interested in making sure the benefits of telehealth are known. And then we'll talk about where the application of it has been. And she stated very adamantly that telehealth has allowed us to overcome the barriers related to transportation, work schedules, childcare, acute anxiety, and many times the depression that comes with a face-to-face visit and having to get to the spot of the visit or the encounter, and that the no-show rate has certainly decreased. We had a report from the University of Louisville yesterday in their telecare as it relates to behavioral health, and they stated it was down into the single digits now, and that the outcome of a telehealth visit certainly surpasses the fact of no visit or no session. The fact that this did not require masks, obviously, for a telehealth visit, and that certain individuals with illnesses or disabilities who struggle with some of the new norms are able to receive the services they need to receive without that anxiety. Finally, it is a very efficient and effective model, and it has become preferred by many who receive behavioral health services. So we're going to talk about 2 primary areas where it has been applied in behavioral health, and that will be for in and outpatient services related to behavioral/mental health, and then we will also talk about SUD treatment. The rounding in various facilities, especially at Bingham Gardens, Hazelwood, Oakwood, and Outwood, has been conducted with telehealth. We have found that at least specialty clinic in Louisville that it has been used for psychiatry, medicine, neurology therapies, and some dentistry. Group therapy has been done at the community mental health centers. And it's being used throughout those centers in the group therapy setting. In addition, working with the judicial branch and the administrative office of the court, the proceedings for involuntary commitment hearings have been done via telecommunications, and also being able to engage with family members by telephone is also has been effective in many ways, where before they may have been unable to be part of a process. Finally, the increased access to substance use disorder treatment via telehealth is extremely important. Without the continuation in recovery, and without the ability to continue those support systems, therapy, meds, etc., relapses are just going to happen. And so telehealth has become a very important tool that can be available for SUD treatment, individual therapy as an adjunct to the medication therapy, group therapy in our residential settings where SUD is treated, along with therapists being at an off-site location, but yet being able to conduct is obviously a benefit, reduces exposure to COVID and other types of encounters. The prevention training by pharmacists to federally qualified health center patients has been done along with the prescriptions that follow after that being mailed to their homes. Peer support being done via telegroup on telehealth. And then finally, the typical mutual aid groups where peers can talk with each other, individuals can talk with each other in various support groups. And we have found that actually with using telehealth and teleplatforms for these types of services, people with common experiences are able to talk almost globally with other individuals, and sometimes are more open than they are maybe with their neighbor down the street who may be sitting next to them. And so we have definitely found positive outcomes from using the teleplatforms in the behavioral health area. Now we'll talk a little bit about Medicaid.
Okay. Actions and guidance related to telehealth during the COVID-19 period. We talked earlier, I think it was Nancy who said that we really want to keep all these Medicaid waivers and executive orders and bills and whatever went through to provide enhanced services in place. So I'm not going to read each one of these, but we have 3 different pages of those that Medicaid did put in place. So I'm going to flip on through because I know we don't have much time. But I will tell you that what we did in the program was we went out and looked at all guidance that were in place, all actions and guidance that related to telehealth across state government. And so I have a 12-page document that has all of that information in it. And so that we can take and look at if we had to roll back or if we were required to roll back and there was an extension, then we'd have to go back and look at regulations and amend those regulations. So we're looking at Medicaid claims data right now. And we looked at 3 months of services using telehealth, which was pre-COVID, and it was $1,093,910. And then we looked at 3 months of services using telehealth during COVID-19, and it's up to $31,791,510. And we looked at our top providers using telehealth. And those are the orders that they come in. The community mental health centers were first. And of course, our behavioral health, specialty groups and organizations, BHSOs were second and third, physician groups, and so on and so forth. And then, and that was for our MCOs. This one is for fee-for-service. So fee-for-service for the first 3 months, which was pre-COVID, was $95,686. But for 3 months of services using telehealth during COVID-19 was $6,953,575. Again, we've looked at the top providers using telehealth for fee-for-service.
Donna, I hate to rush you all, but we have several presenters still after you. So I know that we can make all of these slides available to our members. And I just wanted everyone to see what the cabinet was or had in progress and the thoroughness with which you are tackling this. I love the work group ideas. And I had a conversation with the cabinet earlier today, and I believe that legislators can participate in these work groups if they'd like. So I would love to just make these slides available to everyone and be able to follow up with you. And if you can wrap it up just in the next minute or so, we're going to have to move on with our other presenters because we're running late.
Sure. The number one thing that we have on our plate is the recommendation for encouraging the use of telehealth is connectivity. And you have already said it so many times. To give you some statistics in Kentucky, Kentucky ranks 40th in the state for broadband access. In total, there are 177 internet providers in Kentucky. There are 257,000 people in Kentucky without access to a wired connection capable of 25 megabits download speeds. There are 561,000 people in Kentucky that have access to only one wired provider, leaving them no option to switch, and another 142,000 people in Kentucky that don't have any wired internet providers available where they live. So how are we going to expand the access to healthcare using telehealth if we don't have the foundation in the state of Kentucky? I know we have Kentucky Wired, and we're working with them right now, but that's the middleware. So we've got to get the first mile connected to them. We've got to get the homes connected. So that's our big thing. And the other thing, moving on down, is our policy and regulations. So, we've got to look at those, and we've got to make changes in those for the licensure board to be able to accommodate using telehealth.
Okay, I completely agree. So thank you. I'm so sorry to cut you off because I know that this is important information and it's something that we all need to know. So like I said, we're going to make all these slides available to everyone. And maybe we'll have you back another time to elaborate once we have more information from the work groups. Yeah, thank you so much.
Thank you.
Okay, so I'm going to move on to the rest of the group. If Dr. Wright wants to just kind of fill us in quickly on what is happening with providers on a whole in terms of telehealth, and maybe having all the information that the cabinet just gave us is helpful to all of you to know that we're looking to expand this. So the floor is yours.
All right. Thank you, Chairwoman Moser, Chairman Alvarado, and members of the committee. I've got prepared remarks. I know we're into overtime right now, so I'm going to be keeping those prepared remarks down and try to hit the highlights. So if you will bear with me as I move through this. If you think about COVID-19, how many people were really thinking about telehealth? It was in unique sectors that people were talking about the unique aspects of telehealth. But when COVID-19 hit, what that really showed us was that telehealth became personal protective equipment. And with social distancing, physicians had to rethink their practices completely, because what we're taught to do is to see patients in a one-on-one setting, face-to-face. And what happened with COVID-19, the best way to face that, paradoxically, ironically, was we needed to keep patients away. And what telehealth did, if you look at the history of the state of Kentucky, we have some very progressive legislation. In 2018, we have Senate Bill 112 that Senator Alvarado introduced. It made Kentucky very progressive and very friendly when it came to telemedicine. We also have other champions of that legislation on the call today. But what happened with COVID-19 was we moved quickly when the pandemic started and transformed our practices to make sure we could deliver care to patients, because telehealth is easier and faster to interact with patients and allows them to stay well at home. Early data that we have shows that physicians' offices and hospitals are relying more on treating patients remotely. In mid-April, KMA conducted an online survey of member physicians regarding the impact of the COVID-19 pandemic on their practices. And the survey covered several topics, included the utilization of telehealth services. And more than 300 physicians completed our survey, with nearly every corner of the state participating in a wide variety of specialties represented. And the results showed their dramatic increase in patient visits conducted via telehealth. Approximately 74% of physicians indicated using telehealth during the pandemic, despite only 10% having used the service on a regular basis before. This represents a remarkable shift in the way physicians and other healthcare providers deliver care. But it's been mentioned here before, and I'm glad I have a friendly audience here today. We were only able to do this because we had help with restrictive state and federal rules. And even when we came into the later stretches of the concern with COVID-19, we found that despite using telemedicine and despite the lessening of regulations, we needed to still connect with patients because there are patients out there that do not have the technology to connect both audio and video to their physicians. But we do have that technology in the form of phones. And there was a simple solution: let patients use their phones. But at no time did anyone cover phone calls. And KMA and other stakeholders got together and pushed insurers to loosen their rules. So to the greatest extent possible, cover patients talking to their physicians over the phone. To their credit, public and private payers eventually recognized this fact and allowed greater use of phones for telehealth services. Physicians and patients responded and started connecting. All it took was common sense approach operating outside of the box during a crisis. And as a result, we learned a few simple things that can improve health of our citizens and ensure better care for the future. Mention regulatory hurdles. The things that we need to have help with and look at monitoring going forward is removing certain HIPAA restrictions has allowed platforms such as Apple FaceTime, Google Hangout to move forward with providing this type of care, honoring true payment parity, removing geographic restrictions. We need to make sure people can receive telehealth in their home across the country, not just in rural areas, but in urban areas as well. Utilizing telehealth visits and telephone only services for new and established patients, and allow remote patient monitoring services to both new and established patients. The real question is, are we going to continue to use telehealth as we move through the coronavirus emergency? And we are hopeful and committed to advocating for such changes because there's so much potential, not only to increase convenience for patients, but to keep people healthy, to save the system costs, to help those in rural areas as well as urban settings who may not have the opportunity to see a physician in person. This is not about removing people from care, but it's about bringing expertise to the patients who need it. Within traumatic times, innovations arise that address need, and I hope the use of telehealth is an innovation which will continue long after the challenges of COVID-19. After all, the motto of the state's coronavirus activity is healthy at home. What better way to be healthy than to provide health care to your home from your physician via commonly used technology in the form of telehealth, whether in the pandemic or beyond. Chairwoman Mosher, that completes my remarks. I'm happy to answer questions and speak more to the physician perspective on this. We appreciate everyone's leadership who's on this call, and the KMA remains committed in this area to provide care to our patients and the citizens of the Commonwealth. Thank you.
Thank you very much, Dr. Wright. We look forward to working with KMA and all of our providers on best practices moving forward. It sounds like we all know that we need to expand telehealth. So thanks for that. I know that we still have Dr. Schuster and United Healthcare. So Dr. Schuster, do you want to give us a real brief little overview of behavioral health and the benefits that you've seen?
Yes, thank you so much. And I'm not going to use my PowerPoint because you've got it. And there's no point in going through and just reading it to you. I will tell you that I heard from all sectors of the behavioral health community in a very informal data gathering. We know that the CMHCs, for instance, could not open because they didn't have PPE. They got no PPE from state agencies, so they had to go immediately to telehealth. And they went from zero use of telehealth to as much as 75 to 85% of their patients. And we heard that across the board, that it was not unusual to see low percentages of patients initially using telehealth and then growing to, in some cases, as many as 90% of current patients. And we saw all ranges of ages. We saw all ranges of presenting problems. We saw it on the mental health side as well as on the substance use disorder side. We had problems with very young children, and I think everybody would say that the elderly, especially with limited technology, patients with limited cognitive abilities, patients with paranoid symptomatology were reluctant to talk into a screen. Patients with language and cultural barriers, some of our patients on the autism spectrum, certainly homeless patients, had difficulty connecting. The major barriers, as we know in Kentucky, is the lack of reliable internet connections. And that's not just a rural area problem, unfortunately. The other thing is that many of our patients have limited phone minutes or data. on their phones, and particularly when schools were going using internet capability and so forth, they had to choose between using their limited minutes to get their kids some instructions were not available then to connect with telehealth services. We had some patients who were reluctant to use it, and we had some concerns about privacy and confidentiality when a kid is in the middle of a home setting and trying to talk about very sensitive issues. That was a problem. There have been some billing and reimbursement issues, but largely they've been overcome. I guess the word from the behavioral health community is that telehealth is a critically important tool in the toolbox. It's not necessarily a one-to-one substitute. You still have to do lab work. You still need face-to-face in some settings. But if you've got working technology, you've got a willing client, and you've got a willing provider, you can typically use it. We also found that there were some for whom they opened up. Adolescent boys, for instance, really like communicating with their therapist via telehealth. That's a known and trusted means of communication for them. It certainly helped address transportation issues, lack of childcare, difficulty taking time off from work, and so forth. I think we need to be careful. And you mentioned, Chairman Moser, the health disparities, because telehealth could actually drive those disparities greater. We worry about rural Kentuckians being left out. We worry about those in poverty who don't have access to broadband or don't have access to smartphones or phones with more data or minutes, and those who have limited English proficiency, who have a difficulty using telehealth. So I think we need to be careful about those. Overwhelmingly, our clients liked it, and I think Dr. Wright would agree. I think the hospitals would agree. The no-show rate has practically disappeared. The same-day cancellations have practically disappeared. So in terms of getting services to people, telehealth has been really a godsend. We have had clients and family members express their appreciation through the NAMI group and through our consumer peer drop-in centers, particularly with telephone. And I think whatever we can do to keep telephone as a covered modality, I would really urge us. And we're certainly here to work with all the legislators to make sure that that happens. I think we need to gather more information systemically. We're comparing this with no telehealth and now telehealth during COVID. What will happen when we start opening up and people need to wear a mask? I think people would prefer telehealth to coming in and wearing a mask. It's going to be very difficult to do psychotherapy. You can't see a person's face and you can't read their expressions and so forth. We worry, quite frankly, about the increased needs for behavioral health post-COVID. I think we've all heard the stories about increased depression and anxiety, about substance use disorder, people in recovery who have not been able to stay in recovery. And I think the PTSD that some of our frontline workers. So we really need this tool to be available. We need to make sure that the licensure boards are not putting requirements in that get in the way. We need to make sure there's not that a requirement for an in-person first visit. But behavioral health, I think the data and I think the outcomes and I think patient satisfaction as well as provider satisfaction would say that it has been an absolute godsend. And I think has really helped address actually some mental health needs that were not being addressed earlier because people couldn't get into their services. So my PowerPoint is there and my email. Of course, I'm happy to answer any questions. And I appreciate the opportunity to have a chance to talk to you about behavioral health.
Absolutely. Thank you, Dr. Schuster. And we will absolutely follow up with you. I don't know if Senator Meredith had to jump off to chair his meeting. He's been extremely patient with us. We are probably going to be kicked off here pretty soon, but I see Kevin Crawford. I don't know if Paul Brophy's here, but if you can just kind of summarize maybe what you're seeing, but we do need to do this really quickly. Sorry.
Yeah, so Chairman Mosier, this is Paul Brophy. Can you hear me okay? All right, so first off, my associate Kevin and I would like to thank you, Chairman Mosier, Chairman Alvarado, the rest of the members of the committee to allow us to speak to just for a couple of minutes regarding telehealth, telemedicine. And just as a real quick footnote, we won't comment anything due to Medicaid because of the RFP protest. So real quickly, and I'll try to summarize some of my prepared comments. So telehealth and telemedicine are often used interchangeably, right? But when we use the term telehealth, we are referring to using technology to provide healthcare and services at a distance. And we've heard a couple of things about modalities this afternoon. So for us, telehealth does include all types. So synchronous, so it's real two-way interaction, and then asynchronous, so store and forward type technology, where we're using apps on mobile phones to transfer information. We also use the term telehealth to encompass all types of care. So at United Healthcare, when we talk about telehealth, we're talking about telemedicine, telepsych, and telepharmacy services. And as one example of these services, pre-COVID, we had approximately 1,000 of our in-house doctors using telehealth. Today, we now have 14,000. So from what we've seen so far, telehealth is absolutely here to stay, even when we get back to normal. Virtual visits are expected to surpass 1 billion by 2021. We're seeing adoption across all spectrum, all segments, whether it's commercial, Medicaid, Medicare, et cetera. And I'll share a couple stats relative to what we're doing here in the state of Kentucky with our teachers retirement system customers. Regarding telemedicine, we have two methods of connecting with doctors. Now patients can call to make an appointment, and that appointment will likely be a telemedicine appointment. We also offer and have for many years a comprehensive national virtual network of physicians that can help consumers when they need care immediately without an appointment. We obviously call these virtual visits. And I wanted to point this out because it's very simple for a patient to make an appointment. Patients can see and speak to a doctor anywhere, anytime on a mobile device or a computer. No appointment is necessary, and a visit usually takes less than 20 minutes. Doctors are able to diagnose a wide range of non-emergency medical conditions and prescribe medications if needed. About 70% of these visits are related to colds, fevers, and the cost is typically around $50 on average versus $190 for urgent care or upward of $1,700 for an ER visit. As I mentioned before, we also have telepsych capabilities that are worth us talking about for a few moments today. And our healthcare provider side, more than 200,000 of our Optum behavioral health providers are now able to deliver care through alternate technology. Early claim data indicates a significant shift in the use of telehealth for behavioral health care. Normally, about 2% of all behavioral health claims Optum receives are for telehealth. By the end of March, we're going to estimate that about 33% of our behavioral health care through Optum will be through a telehealth visit. We do also services to patients seeking treatment in community mental health centers through our Genoa pharmacy service. And I wanted to mention, we actually have 9 Genoa pharmacies here in the Commonwealth. Also want to mention our remote patient monitoring capabilities. Remote patient monitoring allows frequent engagement with people who need a bit more care. This typically involves sending out equipment to our patients like thermometers, scales, iPads, etc., so we can collect health information from patients to monitor compliance with medications and ensure we have an early warning if health is deteriorating. We tailor this technology to clinical pathways to match the patient and their condition. So while COVID-19 struck, we identified patients we felt should not miss any doctor care. Think about diabetics as an example. We sent them remote monitoring kits to ensure they got their prescriptions so they would stay healthy when their doctor's offices were closed. So I mentioned the teachers' retirement system. This is a very important partner to us here in the state, and they began pushing for telehealth services years ago. It's been a strategic goal for TRS to increase virtual visits and telehealth telehealth utilization, especially for those retirees in rural areas that we've all been talking about today, to ensure access to care and providers. So these efforts included newsletters, mailers, campaigns. We did promotion of our UHC nurse line and house call program, hosted retiree workshops, and used a lot of social media. And what I really wanted to point out is these results. We saw a 60% increase in medical virtual visits from 2018 to 19. We saw a 30% increase in behavioral health virtual visits from 2018 to 2019. And year to date through June, virtual visits are up 46% over the same time from 2018 for the same time period. 2020 telehealth results are pending, but we have no doubt that they will continue to be on the rise. So I'm going to conclude my comments there. But on behalf of United Healthcare, our many employees who live and work here in the Commonwealth, we thank you for your time and look forward to further discussion around telehealth.
Absolutely. Thank you so much. And I appreciate your brevity. I know that, everything that kind of got squished here at the end, but I would love to, I think there are going to be plenty of opportunities to talk to all of our healthcare providers and our third-party payers in the future about telehealth and all that we can do to really bolster this for our patients. So thank you very much for being here. Thanks everyone for your patience. We're going to wrap this up quickly. I need to know if there are any members who need to record their presence who didn't do that in the beginning. Anyone on the call?
Here at home.
George Brown at home.
Okay, thank you. Anyone else who did not record their presence? Okay. Well, thank you very much. We are going to move into the Medicaid Oversight Advisory Committee right now, I think. So I will entertain a motion to adjourn, seeing no further business. And I want to thank everyone again for, okay, thank you. Okay, we are adjourned until our next meeting on July 29th.